At CPR Florida, we teach CPR, BLS, First Aid, ACLS, and PALS classes. People always ask us about taking the American Heart Association ACLS and PALS classes. That's very simple to register. You just pick the date, time, and class that you want. We have 5 offices to choose from. For example, here we can see it's Pompano, but it is the BLS and ACLS combo, or we have BLS, ACLS, and PALS combo, which is so convenient, and you can do it in one day if you do the study material and the free ACLS or PALS pretest ahead of time. We also have separate ACLS and PALS classes as well, all at CPR Florida, easy to sign up. Here's some more information. Watch these videos so you can see more.
Our conscious patients, that they may still require some advanced assessment and actions without the use of the BLS. The hope in these situations is to try and prevent the further deterioration and then eventual arrest of your patient. Now, the systematic approach for the primary assessment involves a series of assessments and then actions using the ABCDE model. All right, so here A stands for our airway, B is for our breathing, C is for our circulation, D is for our disability, and then E is for our exposure. So to begin, we want to maintain the airway of our patient. And this is going to be using something like the head tilt chin lift, as well as using a device like a nasopharyngeal or an oropharyngeal airway to help keep that airway open. Now here you guys remember, please don't use an oropharyngeal airway if your patients are awake. In addition to this, we do want to utilize an advanced airway if it's needed. So in almost all inpatient settings, this is going to mean intubation. Now, if our bag valve mask though is sufficiently working, then we're often going to be delaying intubation until the patient hasn't responded to our initial efforts with CPR. Now, once we do have them intubated though, it's going to be really important that you are confirming placement of the airway, both by verifying that you have equal chest rise and that you are auscultating bilateral lung sounds. In addition to that, you want to be using end-tidal CO2, also referred to as our waveform capnography, and this is going to be used both to verify placement and for continued assessment moving forward. And then finally, make sure you have the endotracheal tube secured to your patient. So when it comes to our patient's breathing, that we want to be utilizing the bag valve mask to ensure that we're providing them supplemental oxygen, supporting their ventilation while not excessively ventilating the patient. Now, if you're in a code situation, use 100% FiO2 through the BVM. Otherwise, you want to be adjusting the FiO2 to maintain at least sats at 94%. And so if you guys don't have it already, this is where we want to be using our end-tidal CO2 and our pulse oximetry, or SpO2, in order to really be able to assess our patient's breathing. Now, moving on to our patient's circulation, this is where you're really going to want to ensure that you have the proper depth and rate of compressions. And this is both through observed as well as watching our end-tidal CO2, where we want to have at least 10 to 20 millimeters of mercury, but more likely closer or greater than 20. Now, first and foremost at this point is you want to assess whether you have IV-IO access. And if it's not present or it's not functional, then immediately get access. Trust me, the last thing you want is to not have functional access when one of these situations happens. Now again, if it's not already done, then we want to have our ECG monitoring going on, and we want to be keeping an eye out for any arrhythmias, and then obviously defibrillate those as needed. Now we're going to give them any appropriate drugs and fluids that are needed, as well as this is also the point where you want to check a glucose and a temperature. And then really we want to be watching for if we have achieved ROSC. So this is the return of our spontaneous circulation. And how do we know? Well, check a pulse. Do you feel a pulse with an organized rhythm on the ECG? Also, if you have your end-tidal CO2, you're going to see an abrupt rise in the CO2, generally greater than 40 or more. So now that you've done all that, at this point we want to be checking for disability in our patients, and this means checking their neurological functioning. So this is going to include our basic assessment of responsiveness, level of consciousness, and the patient's pupillary reflex. And so when it comes to assessing their level of consciousness, it helps to remember APVU, APVU. This is our alert, voice, painful, and unresponsive. And then finally, the last part of this primary assessment is going to be our patient's exposure. And this really means that we want to uncover the patient from head to toe and visually inspect for if there's any obvious signs of any potential issues. And this can be for things like trauma, bleeding, burns, any unusual marks, or even looking for any alert bracelets. Now, the key thing to remember with all of this that I just talked about in this primary assessment is that oftentimes, especially as you have more experience and you have more experienced teams, that many of these assessments and their actions are going to be performed simultaneously and not necessarily in a step-by-step fashion.
Push that analyze button and allow the AED to analyze the person's heart rhythm. If a shock is recommended by the AED, we want to again make sure that nobody is touching that patient, and we want to repeat, stand clear. Be very direct when you say that. You don't want somebody getting a shock when they don't need it. Once everybody is clear, we're going to press that shock button. After we press that shock button, what do we want to do? We're going to begin CPR again immediately. Start with those chest compressions following that shock. If no shock is advised, then of course we go back to doing our chest compressions. We perform those 2 minutes of CPR, and then we follow the AED's prompts again during the next cycle. So we pretty much covered a lot of what the BLS wants you to know. So let's move on to our ACLS and start talking about those rhythms. So we have 3 sets of rhythms that we're really usually concerned about. That's our bradycardic rhythms, our tachycardic rhythms, and our lethal rhythms. So let's get started on looking at our bradycardic rhythms, starting with sinus bradycardia. It's not always a bad rhythm. The rate is less than 60 beats per minute. The rhythm is usually regular and initiated by the SA node. P waves are normal and upright. The PR interval lengthens as the rate decreases, and our QRS interval is usually normal. It's less than 0.12 seconds. This is normal in our well-conditioned individuals, such as like our athletes. So we usually don't do anything with this unless the patient is symptomatic. Moving on to our heart blocks, we have a first-degree heart block rhythm. This is a rhythm that we really want to be cautious with. The rate is usually dependent on what the underlying rhythm is. It's either usually a sinus rhythm or a sinus bradycardia. Rhythm's usually regular, and our P waves are regular and always precedes each QRS complex. The thing that makes this different is the PR interval is greater than 0.2 seconds. QRS is always normal, it's less than 0.12, and it's the most common rhythm that you'll usually see in the heart blocks. It's usually caused by an increased delay at the level of the AV node, causing a prolongation rather than a real true block. So sometimes we do something about this, sometimes it resolves itself. It's really one of those labile rhythms. Moving on to our next heart block, it's getting a little bit worse. So we have a second-degree heart block type 1 rhythm. So the rate is dependent on what the underlying rhythm is. The rhythm is usually irregular. P waves are usually normal. The PR interval usually lengthens. So what you'll see in this is that the P wave will lengthen, and then you have a drop in the rhythm. Your QRS is less than 0.12 seconds, and like I said before, the definition of this is lengthening of the PR interval until the impulse is blocked and the QRS drops in this repeated pattern. So now we have our second degree heart block type 2 rhythm. So the atrial rate is usually faster than the ventricular rate. The rhythm is still irregular, just like with our second degree type 1, and our P waves are occasionally conducted. So the PR interval is usually consistent. That's what makes second degree type 1 and second degree type 2 very different, is you have consistent PR intervals when you have them. The QRS is usually greater than 0.12 seconds usually, and that's because there's a block within or below the AV junction within the changing conduction ratio. So PR intervals never change. They can progress to a third degree heart block, which is really bad, and usually sometimes with these patients, we might have to pace them. So moving on to that big bad boy rhythm, third degree complete heart block. So with this one, the atria is usually 60 to 100 beats per minute, and that ventricular rate is much slower. It's usually less than 40 beats per minute. So with this rhythm, the atria and ventricular rhythms are independently regular and not associated with one another. So like in our normal sinus rhythm, Our P is always preceded by a QRS and it's very regular. This is still regular, but they don't talk to each other. They're not communicating, right? So P waves are normal, but there's no relation to the QRS like we discussed before. You're not gonna see those PR intervals, and those QRS intervals are really gonna vary. So the definition is there's a failure of the atria and the ventricles to synchronize contraction. So you're gonna have those regular P to P intervals and regular R to R intervals, but they're not gonna match each other like they should. So the atria rate is gonna be normal and the ventricular rate is gonna be Brady.
Shockable rhythms. The way I remember which rhythms are shockable is with my little jingle. And it goes, D fib for V fib impulseless B tach. Don't defib asystole, you won't get them back. D fib for V fib impulseless B tach. Don't defib asystole, you won't get them back. That being said, I do know that in real life settings that they do occasionally shock what appears to be asystole, because the rationale is that maybe it's a very fine V fib and we're going to shock them to see if we can get them back. But on a test, remember, this is me preparing you for a test. In the test world, you do not shock asystole. That is the incorrect answer. That is the incorrect intervention. So defib for VFib and pulseless V tach. And defibrillation, the biphasic initial is 120 joules to 200. If unknown, use maximum available. Second and subsequent doses should be equal, and a higher dose may be considered. Monophasic is 360. And use the suggested manufacturer joule setting on the unit. With the 2020 updates, a lot of times what they're saying now is we're going to refer to manufacturer settings versus them actually testing you on the joules that should be delivered. Drug therapy for shockable rhythms, epi. We're going to do epinephrine 1 milligram every 3 to 5 minutes. Amiodarone, first dose is 300 milligrams, second dose is 150 milligrams with a max of 450, or lidocaine, first dose 1 to 1.5 milligrams per kilogram, second dose 0.5 to 0.75 milligrams per kilogram.